Hi, this is Brian Kim. I'm going to share with you this case of a patient with intraoperative floppy iris syndrome and why, in my opinion, double chop, cross chop, and mechanical fracturing is the single best technique when you're dealing with IFIS. And so this is the idea. Remember, IFIS is like this floppy iris situation. And think about it. That only happens, and it's like billowing sails in the wind. And the wind is when there's fluid in the eye, right? So if there's fluid in the eye, you're going to have this billowing effect. But normally we have dispersive viscoelastic to tamponade the iris down. And so in theory, if you have viscoelastic in the eye, then you should not have that billowing effect. And so that means when you put the viscoelastic in the eye, you need a technique that keeps the viscoelastic in the eye as much as possible when you're doing the case. And that means you have this donut of viscoelastic that's tamponading the iris down, almost like bags of cement that are holding down the pupil and the iris. And then you have a technique that only works in the central safe zone, and you're only activating vacuum and aspiration only in the central safe zone. As long as you're doing that, then you're not going to disturb the sandbags that are there, and therefore you're not going to release and liberate the iris, which will start to billow with the currents of the fluid that you're pushing in, the irrigation fluid. And so therefore, when you have a technique like double chop, cross chop, mechanical fracturing, the one I developed, you're bringing all the maneuvers towards a central safe zone. You're fracturing without using any vacuum. Remember that. You're not using vacuum when you're fracturing. You're not using ultrasonic energy when you're fracturing. And you know, all the traditional techniques, you have to grab pieces with vacuum. That's the way we're taught. So you grab pieces in the bag with vacuum, you go near the iris with vacuum. And so all of that vacuum that you use, little by little by little, removes each of those sandbags that are holding down the iris. And so if you go around using a technique that really depends upon and is really crippled by being utterly dependent upon using vacuum to mobilize pieces out of the bag, then you're going to be removing each of those sandbags. And therefore, when you remove those sandbags, suddenly the iris is going to run rampant whenever it's encountering the irrigation fluid, and it's going to start billowing and moving around all over the place while you're doing the surgery. And so this is why double chop, cross chop, mechanical fracturing is by far the very best technique to deal with this situation, because you're bringing all the action into the central safe zone. You're fracturing just with mechanical forces. You're pulling pieces up out of the bag using the chopper. You're only using the vacuum and ultrasonic energy in the central safe zone. And so therefore, you're not really noticing any billowing until at the end of the case. Why? Because you got to remove the viscoelastic at the end of the case, and that's what you will see in this particular case. So here's the beginning of the case. You can see I'm using a corneal marker, which will help me to center and size the rhexis, and I'm using the cotton tip to steady the eye and center the eye as I do this. I'm turning the eye towards the left with the cotton tip, which will allow me to create a nice corneal shelf with my paracentesis incision parallel to the iris plane, and making that flat approach will allow me to create that corneal shelf, which will allow me to achieve that self-sealing incision. This is some intracameral lidocaine and some intracameral epinephrine, and then now some dispersive viscoelastic. As you can tell, so far you can't really tell this is an IFIS case. You did see some viscodilation, which was pretty impressive when I put the viscoelastic in. That is a little bit of a clue that this could be an IFIS, but not necessarily. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then enter when I'm ready to create and control that length of the incision. So this is the sharp tip Halti Percars. I'm going to puncture the center, tease to the right, grabbing the right side of the tear. And again, I used the corneal marker before, and that's going to be my guide to help set and lock my rhexis size, shape, and location. So go around circumferentially. Again, the low profile rhexis forceps allows me exquisite control as I do the rhexis here, and I'm able to follow that mark very nicely, very well controlled here. Finish off the rhexis, burp some viscoelastic out, and this is the capsulorhexis hydrodissection technique. Of course, with IFIS, you want to be very careful about over-aggressive hydrodissection, and so you saw I did a nice wave, and then loosening up on the left side, and then on the right side, I'm able to hook the peripheral lens, and the lens begins to spin. Irrigate the surface of the eye lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma, placing the chopper in, activating irrigation, removing the surface epinuclear material, placing the chopper underneath the rhexis edge, tilting the phaco tip vertically sub-incisionally, bringing the instruments together, and that fractures the lens in half. That's double chop, placing the chopper around the right heminucleus, pulling it centrally toward the phaco tip, and that is cross chop. All of that maneuvering was done just with irrigation, no vacuum, no ultrasonic energy. Again, it does not disrupt the sandbags as I'm doing the case. I'm able to pull that first quadrant up, crush the pieces in the central safe zone, and then emulsify the lens piece. Lifting that second quadrant up out of the bag, sandwiching the lens pieces between the instruments, crushing it, and then removing the lens piece and emulsifying it. By working in the central safe zone, you're able to keep the pupil relatively controlled as you're doing the maneuvers. You're not going near the iris, which you might accidentally grab. And again, you want to think about the viscoelastic like sandbags holding down the iris. By going after that area with vacuum, you're just removing the sandbags, and that's really counterproductive when you're doing cataract surgery in an IFIS situation. So I turned that second heminucleus in front of me and placing the chopper around the lens, pulling it centrally toward the phaco tip and fracturing it in half. I'm breaking down that third quadrant very carefully, and again using pulses of ultrasonic energy as well as vacuum to do this. You can see on the right side, on the fluidics, I'm constantly doing an on and off, and on and off. I'm doing an on and off. I constantly do that because I'm modulating and controlling the vacuum and ultrasonic energy throughout the entire case. Again, as long as you're using sparing amounts of vacuum and positioning it in a way that it's not close to the sandbags, you're going to reduce the risk of having that IFIS situation. Because remember, the billowing of the iris is like billowing of the sails in the wind. If there's no wind, there's no billowing. And so billowing is essentially wind, which is essentially when you only have fluid in the eye, right? If you have the irrigation fluid, then it's going to start billowing like crazy. But if you have the viscoelastic tamponading the iris down like sandbags, that shouldn't happen. So I'm moving the epinuclear material here at the end of the case, taking the chopper out, push BSS in, take the phaco tip out, and I go in with an I&E handpiece. You can see the pupil opened up nicely, a little bit of reverse pupillary block, which is actually welcome in this kind of situation. So reverse pupillary block is not always a bad thing. You can actually leverage reverse pupillary block in this situation because it helps tamponade that iris, pull it away back, and it allows you to do the cortical cleanup without worrying about grabbing the peripheral iris. So again, reverse pupillary block is not always bad. In this case, you can leverage using the reverse pupillary block to help protect the pupil and the iris in IFIS cases. So remove all the cortical material. Now I'm polishing the capsule underneath the rhexis edge as well as the posterior capsule here. Of course, this is a smallish pupil. It's starting to shrink a little bit as I do these maneuvers here. I'm going to very carefully pulse the subincisional capsule forceps just to make sure it's clean here. And I do that because I do see the edge of the rhexis, and so I felt comfortable doing it that way here. Very carefully, I'm going to come out. But before I do that, I'm going to push the cohesive viscoelastic first, turn off the irrigation, and then come out. And then I want to polish underneath the rhexis edge here very carefully. Again, not too aggressively because the view is really a little bit limited here. Polishing on the other side. And this is a single piece acrylic lens. It's going to go into the capsular bag. The leading edge is going to go into the bag. And I turn the eye away from me. I can see the rhexis edge as I do this, making sure it goes into the bag. As it unfolds, I go ahead and place the I&A handpiece in, activate irrigation, making sure the haptics come off the optic, getting underneath the optic, tilting and rotating 90 degrees clockwise, which ensures that both haptics are in the bag, removing all the viscoelastic from within the bag because you don't want that optic to pop up, especially in this case when the pupil is smaller. Polishing underneath the rhexis edge, making sure that I can see the iris. You saw that I was kind of teasing the lens, and that ensured that the haptics were both in the bag, and then remove the viscoelastic from the anterior chamber, and then I'll hydroband incision. So you can see at the very end, when I remove all the viscoelastic from the anterior chamber, look at all that billowing. So again, that is essentially what I'm trying to say. you shouldn't see billowing until the very end of the case, because that's when you remove all the viscoelastic. If you have a lot of billowing at the beginning of the case, guess what? That means you removed all that viscoelastic, and you shouldn't have done that. And so that goes to show your technique is limited. You shouldn't have a technique where you're using so much vacuum at the very beginning of the case. If you're using a lot of vacuum at the beginning of the case, you're removing all those sandbags that are holding down the iris, which is helping you control the IFIS. And so, again, this is perfect illustration as to why double chop, cross chop, mechanical fracturing, and these techniques that I've developed are such powerful techniques, because in this case, you're able to disassemble the lens using pure mechanical forces. You don't have to go after pieces with vacuum. You hook the peripheral lens pieces up with the chopper into the central safe zone using sparing amounts of ultrasonic energy and vacuum in the central safe zone. And as you saw in this case, only at the very end, when I'm removing the viscoelastic intentionally out of the anterior chamber, that's when you start to see the billowing from this IFIS case. And this is why I strongly believe double chop, cross chop mechanical fracturing is the single best way to handle the IFIS situation when you're doing cataract surgery. So I hope this was helpful to you, and I thank you for your attention.